morning again. So I'll be discussing few cases for the importance of shallow anterior chamber detection and significance. No financial disclosure. My first case is a 50-year-old lady who presented to us with a chief complaint of headache which increased while reading since 1 year. Her last ocular examination was done 2 years back where she was prescribed presbyopic glasses. However, she was not using it. Her intraocular pressure was 14 and 16 millimeter of mercury. There was no significant medical history. She was using lubricating eye drop on and off. There was no family history of glaucoma. Her best corrected visual acuity was 6 and N6. Intraocular pressure was 12 and 13 millimeter of mercury, and central corneal thickness was 510 and 530 microns. On diffuse illumination, anterior segment was found to be normal, and on von Herrich's grading, anterior chambers were found to be deep. So a patient, a middle-aged female coming with a complaint of headache, we made a where fundus was normal, slit lamp examination, anterior chambers were found to be deep. We made a diagnosis of both eye
How many people think this could be related to glaucoma in any way? None. Okay. One. Okay.
So since she was complaining of headache which increased while reading, one could be the cause because she was not using her headache, she was not using her presbyopic glasses. But we also did gonioscopy for her. So in right eye, in inferior angle was open, still scleral spur. There were few iris processes. Left eye, in right eye, superior angle was narrow, which did not open on indentation. In left eye, inferior angle was open till scleral spur, and there were few iridotrabecular contact. It was a superior angle was narrow, which did not open on indentation. However, on indentation, patchy pigmentation was seen. Can we see here? Patchy pigmentation was there. So now again a female, we then on the basis of gonioscopy, we made a diagnosis of primary angle closure. She was advised both eye laser PI. After this, when we advised her, she told us, she gave us a history that laser PI was done for her father also. So detailed history is very important, and gonioscopy should be done for all the patients. So my second case is a 42-year-old male. He basically came for a second opinion of glaucoma. He was diagnosed as glaucoma at the age of 29 years, and he was put on eye drops, timolol eye drop, and tablet acetazolamide. He was taking SOS whenever there was blurring of vision. He had a family history of glaucoma. His maternal grandmother became blind because of glaucoma. Best corrected visual acuity was 612 right eye, 624 left eye. Intraocular pressure was 12 millimeter of mercury and 15 millimeter of mercury in left eye. On diffuse illumination, we can see anterior segment was normal. On slit examination, von Herrich's grading, anterior chamber was found to be deep. So when we did fundus examination, he was found to be a myopic patient. There were myopic changes in the fundus. Disc was normal. So the probable cause for reduced visual acuity is because of myopic changes, which was present in macula also. So a diagnosis of both eye glaucoma with myopia was made. So the next question, whether should we allow the patient to continue the medicine or should we stop because he has a family history also. Next, we did gonioscopy for the patient. Right eye inferior angle was open. However, there was anterior bowing of iris was present in the periphery. Superior angle was narrow, which did not open on indentation. I don't have the picture of left eye inferior angle. However, it was open. We can see that superior angle was narrow, which did not open on indentation. So now our diagnosis changed. Initially, it was myopia with glaucoma. Now, after doing gonioscopy, it became myopia with primary angle closure. So the patient was advised laser PI. So we know even though the antechambers are deep and normally in myope, still this patient had primary angle closure, and hence we should do gonioscopy in all patients, whether they have shallow anterior chamber or deep anterior chamber. So my take-home message is asymptomatic angle closure is common, and gonioscopy is important for all glaucoma patients and suspects.